Hello everyone, it's Hunter Hicks. Today we're going to be looking at dysmenorrhea, amenorrhea, and we're also going to look at some abnormal uterine bleeding. Before we go into that, I think it's helpful just to do some quick physiology on the menstrual cycle. So when we look at the menstrual cycle, we really have two main organs we're going to be talking about here. We have the ovary and the endometrium. We know the endometrium is that inner functional layer of the uterus. Both of these organs are going to respond to different levels of hormones and basically make changes in order to hopefully have a baby in the uterus. Now, typically a menstrual cycle lasts around 28 days. And that's typical, but that doesn't mean that's for everyone. The start of it is technically menses, where people refer to as the period. And what that is, that's really just the breaking down of the endometrial layer or wall of the uterus. When that breaks down, it kind of signifies the start and the continuous of the cycle. We'll see towards the end of this entire cycle, we get back to menses if there is no sperm and we restart again. So really, again, we're going to be talking about the ovary, and we're going to be talking about the endometrium. So the first phase we're going to see is the follicular phase and then the proliferative phase. Now, if you think about a cycle as 28 days, then the middle of that cycle would be 14 days, right? 14 days meaning ovulation usually is when we have ovulation. Well, if you divide that, then the first 14 days are the first half and the second 14 days are the second half. So we're going to break that down. We're going to talk about first half, ovulation, and then go into the second half. So what we have here happening is we have a lot of release of our follicle stimulating hormone, which we know comes from our pituitary gland. We're going to go through the HPO axis after this. But basically what happens is our follicle stimulating hormone comes out. And just like the name says, it's going to go to the ovary and say, hey, start making or growing more of our follicles. So our follicles that are in there are going to grow larger and larger. Well, the good thing about those follicles is they are then able to release estrogen. That estrogen then is going to go down to my uterus and say, hey, I need you to start growing and getting ready in case we have company or a baby later. So then, just like it's supposed to do, the endometrium is going to proliferate, meaning proliferative phase, and get larger and basically get ready. Well, as more and more follicle stimulating hormones going on, one of those follicles, the lucky one, basically gets very large and it gets huge. Well, the big follicle then is able to make a ton of estrogen, and he basically says, hey, I got this. I don't need any more help. What I'm trying to say here is there's a negative feedback loop. As our estrogen goes up, 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 that follicle stimulating hormone says, okay, I'm out of here. You don't need my help anymore. You can do this on your own. As that follicle stimulating hormone decreases, the rest of those follicles do not continue to grow, and only this one that we saw did continue to grow. So just like any endocrine thing we talk about, this is a perfect example of a negative feedback loop. Anyways, this big follicle is doing great and fine. He's still releasing estrogen. All of a sudden, there's this huge release in luteinizing hormone. Okay, luteinizing hormone is just another example of one of the hormones that we get from the pituitary gland or one of our gonadotropins to help out with the female reproductive system. So anyways, huge release of luteinizing hormone that makes this follicle rupture. Well, when it ruptures, we get an ovum, or what we call really a luteal cyst, okay? So that luteal cyst, or corpus luteum, then, is what we go into the luteal phase. Makes sense. Luteal cyst, luteal phase. Well, I just want to make it very clear that when we have that ovum come out and we go over to this side of the second half, we call that ovulation, right? That follicle got big, 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 ruptured. Here comes my ovum. Now we have this corpus luteum or this luteal cyst, and he's like, now it's my turn. I'm going to help out. Well, we talk about estrogen's kind of like the big deal in the first half of the menstrual cycle. Now progesterone is going to take over and help us out. So just like that, luteal cyst is going to make a lot of progesterone. Well, just like we did last time when the follicle took estrogen and said, hey, uterus, I need your help. Now the luteal cyst is going to say, hey, uterus, I need your help, and send down some progesterone down his way. And what that's going to do is increase that proliferation of our uterus, continuously get it ready for a possible fetus. Well, outside of growing, we're also going to increase the vasculature a ton in there, right? So we're going to get a bunch of these good vasculature, really increase the perfusion of that area. And that's awesome. That's what we need to do because we're about to have a living thing in there possibly. So all this is going on and it's going great. Now we call it the secretory phase as well because in addition to this, our endometrium is going to release some kind of glucagon, some nice fluid that's also going to help with nutrition and stuff in that area. Now, if this were to continue the way it was going, well, what happens then is that cyst, that ovum is then going to leave, right? It's going to go for the fallopian tubes into my uterus. If it meets a sperm, that's awesome. We form this cell, then releases HCG. As we continuously release this HCG, it continuously tells my corpus luteum to give me more estrogen and progesterone. Because that progesterone, the estrogen and progesterone will continuously come back to the uterus and making sure we're keeping it nice and perfect for a potential baby. HCG continues to go and you can get it detected almost about 8 days after ovulation. It'll continue to do this until our placenta is ready to go, and then the placenta takes that job over. Now, if that doesn't occur, if there's no sperm or anything like that, well, what happens here is that corpus luteum or that luteal cyst, he's like, well, no one's telling me what to do anymore because HCG would have, but he's not here, so I'm just going to stop. Well, that's what he does. He stops making the progesterone. Therefore, we stop increasing that proliferative factors to our uterus, and basically we stop perfusing the uterus to a degree, right? That little endometrium of nice proliferative creation we have, now we're just not really perfusing it as well, and then we get breakdown of that endometrium, and therefore we get menses, and we start over again, okay? So that's essentially how this goes. Very basic, way more than that, but this is just the most basic way I wanted to bring it up. So now you see what's going down here in the organs, but the guys before this is our HPO axis. So these are really like the control center that are telling the ovary and telling the endometrium what to do. So what we call that is the HPO axis, meaning the hypothalamus, the pituitary gland, and the ovary. Well, our hypothalamus is going to give us the gonadotropin releasing hormone, which then the pituitary gland will give us 2 gonadotropins, which we know are going to be our luteinizing hormone and follicle stimulating hormone. And then the ovaries are like, I got this because I'm going to give you guys estrogen and progesterone. So a lot of times when we talk about issues with bleeding or menses or the cycle in general, it can arise from this HPO axis because as you now see, they are giving the message down to my ovary, which then is helping out my endometrium, and it's this huge, nice cycle. So anything within that can cause issues here. So now let's talk about some of these. So amenorrhea, right, which is going to be the cessation of basically menses. Now let's break this down here a little bit. So we have primary and we have secondary. Typically, and I say typically throughout this video, but it can totally be different ages and different values that I'm giving. But typically, menarche or their first menses usually comes around age 12-ish. Now, if menarche has not came in by around age 15 to 16, we start to worry more about primary amenorrhea, meaning they never had menarche, they never had menses. Whereas secondary means that they have had menarche, but now we have stopped having our menses. Now, when we look at the two differences in causes, primary, right, patients that we know probably haven't quite developed secondary sex characteristics, haven't had menarche, they can have an issue with that HPO axis. And I kind of break it down to 4 classifications. Class 1 could be an issue with the hypothalamus, so that could be a tumor or things like that. Class 2, we worry about the pituitary gland. That could be tumors. We call those microadenomas, which can create a lot of prolactin levels and stuff like that. 3 can be issues with the ovary itself. Maybe it's not making as many hormones as we want, so we could have ovary failure. Okay, and then 4 could just be an anatomical issue issue such as a outlet issue. So we're actually, when we're having the menses, there's just an issue, it's not getting out, and we can't really measure it. Secondary is a little bit different. We can have some of those similar issues, but other things we can have are things like thalamus issues again. We can have patients here that have issues with diet, exercise, so maybe they're dieting too much, maybe they have anorexia, they have bulimia, they have really, really strenuous exercise. Anything like that can also mess with that HPO axis, mess with our hormones, stuff like that. Other things like different kind of ovarian diseases and stuff like that. So subjectively, some things we want to ask them, right, is when was their menarche? When was their last period? Or sorry, when was the last menses? What is the normal frequency, duration? What are they normally experiencing? When was the last time they had one? Really, like how long has it been? The most common cause of amenorrhea in the secondary is obviously going to be pregnancy, right? So we always want to ask them if they could be pregnant. We always want to grab an HCG level as well. Now, other things we want to ask them subjectively, any dieting you've been doing, any exercise you've been doing, have you been taking steroids? We look for that sometimes with some of our power lifters, anything like that. You just want to be asking those questions as well. Objectively, we talked about the HCG level. We want to get that and just rule that out right away if it's could be a cause. For our FSH levels, we want to look at those are high or low, right? If they're low, it could be a primary problem where we're just not giving enough follicle-stimulating hormone. Therefore, we're never telling the ovary and stuff to make those hormones. Or if it's high, it could be ovarian failure, right? If you look at those two organs, the ovary is not giving me estrogen and progesterone. Well, then we go back to where our anterior pituitary gland is. He's like, I'm giving you all the FSH in the world. What's going on? So my FSH levels might look really high, but it's kind of a false high, right? Because they're increasing FSH, but the ovary is not listening, and he's not making estrogen and progesterone. So if it's really high, that doesn't mean that we can just say, oh, everything's okay here. It could be primary related to the ovary. Other things, obviously, we want to check our thyroid levels, which goes subjectively asking our patient if they have any heat intolerance, cold intolerance, any sleepiness, anything like that that you think could be thyroid issues. Prolactin levels we want to check. Obviously, we worry about that with our pituitary gland. High levels of that prolactin can cause issues with our ovulation. Androgens, which is our DHEA, which is looking at testosterone levels. If we think that there's any issues with the androgens, and we could also kind of see that with subjective or objective data on our patient as well. Treatment, a lot of times, depending on what it is, sometimes if it's primary amenorrhea, we can give them estrogen to help develop secondary sex characteristics, decrease risk of osteoporosis, and hopefully help bring on menses. Secondary, treating the cause, again, it could be just a simple diet, exercise kind of thing, or sometimes it could be hormone therapy as well. Now, dysmenorrhea or pain with our menses, very common complaint we can see here. A little bit difference here is primary and secondary. So both of these usually occur around the time of the menstrual cycle. Now, primary usually is going to occur more in our younger adolescents, and it's more kind of the typical what you might see, meaning it usually happens 2 years after menarche, and they'll just typically have those cramping signs and symptoms maybe a couple of days before their menses comes on, or during their menses or start of their cycle. It's usually predictive for them, but that's not to take away that some of these patients don't have extreme pain where they might be bedbound and missing work and stuff like that because the pain is so extreme. Now, primary also has some other things that we got to watch out for that increases their risk. So we have people with low BMI that are at increased risk. Sometimes even family history of this will increase their risk. Secondary, we're going to see more maybe like people or women, excuse me, maybe in their 30s to 40s. And it's usually sometimes secondary to something else, whether that's a pelvic inflammatory disease or very commonly endometriosis. Either way, a lot of pain going on here. And the reason we get that pain is because during our menses, when the endometrium is disintegrating, we get a huge release of prostaglandin. Well, we know what that does, but essentially what it's doing is prostaglandin is causing vasoconstriction of that uterus. Well, over vasoconstriction of the uterus, we can possibly induce some ischemic injury. Therefore, it looks and feels like a cramping. cramping can be extreme. It can be felt in the belly, other areas of the body. We also just get this larger release of prostaglandin in the body, so they can have things like nausea, vomiting, diarrhea, headaches, all those kinds of things going on as well. Subjective and objective, I kind of talked a lot about this. Subjectively, you want to know when the pain's coming on. What's the pain feel like? How long is it lasting? If it's coming on maybe 2 days before and it's pretty self-limiting, we're going more to primary, especially with their age and everything else. If it's lasting like maybe it happens a week before their menses or it lasts a lot longer, and with their age, could be more of a secondary cause. Obviously, any other signs and symptoms that they're having, we want to look at. Subjectively, I also want to know if they're having any issues, right? Could this on my differential diagnosis, could this be a UTI? Could this be ectopic pregnancy? Could this be any other cause that is presenting like dysmenorrhea, but it could be something else causing it? Objectively, kind of all the same things, running tests, labs, depending on what you're looking for here as well. Now, as far as treatment, really what's very helpful here is going to be NSAIDs. Obviously, those are going to block both our COX-1 and COX-2 receptors, but also our prostaglandin. So very helpful here, giving those prophylactically sometimes for menses come on or during it. And then other things like warm baths can help, warm compress can help on the belly. Vitamins like vitamin B, magnesium, vitamin D, all those things have some good research supporting them. Last but not least, guys, we're going to go through abnormal uterine bleeding. So, by definition, what is normal uterine bleeding, I guess? So, the good thing is that the International Federation of Gynecology and Obstetrics has gave more of a formal definition. So usually menses is going to last anywhere from 4 to 8 days, which is like the actual hemorrhage portion of your cycle. It usually occurs every 24 to 38 days, right? Because we know then another cycle is going to start. And as far as the amount of hemorrhage or bleeding, it's around 5 up to 80 cc's. Any alterations in the frequency, duration, or amount of bleeding is what we call abnormal uterine bleeding. Now, tons and tons of different causes. That's why they were very nice to make this nice, I can't think of the word, mnemonic for us to use, which is going to be palm coin. So first, for our polyps, common thing we can see, adenomyosis, okay, which is going to be when the endometrium is going to sometimes grow into the myometrium, which causes bleeding there. Leiomyomata, another cause, which is a fancy name for fibroids. Usually fibroids are pretty atypical, but a common sign if you do have them is bleeding. Malignancy, we read about endometrial and cervical cancer. Coagulopathy, meaning they're at risk for bleeding, so someone with von Willebrand disease, where they don't have a lot of von Willebrand factor. Ovulatory dysfunction is another thing we can see, just issues with the ovulation in general. Maybe they're not having frequent ovulation, so not like once a month, or they're just not having it at all. All these are common things that can cause issues with bleeding as well, and it could just be a hormonal issue as well here, but that's a very common one. Endometrial dysfunction, iatrogenic causes could be like medications, some of your birth controls, other things like that, and then N, not otherwise classified. As far as treatment, hormonal treatment can be helpful here, like progesterone or progestins can help out. Thank you again. If you like this, give me a like, comment if you have any questions, and we'll see you next time.